All right, thanks everybody for joining. This is Carol from the Society of Thoracic Surgeons. This is the Adult Cardiac Surgery Database monthly webinar for August 2nd, 2003. On the line with me today, we have, of course, Melinda Offer, who is our STS Adult Cardiac Consultant, and then we have our special guest, STS President, Dr. Thomas McIlvery. Dr. McIlvery, would you like to, first of all, thank you so much for joining and just hanging out with us today as we go through this webinar. Please feel free to introduce yourself and say hi. Thanks for joining.
Well, thanks, Carol. Hi, everybody. It's really great to be with all of you today. I was talking with Carol and Jane last week, and they told me about these meetings, and I thought it would be really great to be able to spend some time with all of you. I can't thank you all enough for everything you do for the database, for the STS, and most importantly for our patients. Without all of your work, we would not know as much as we do about how we take care of our patients and how we can do it better. So thanks for everything. It's great to be here. I'm looking forward to learning today.
Great. Thank you so much, Dr. McIlvery, and it's an honor to work with such dedicated surgeon and someone who cares as much as you do. So thank you very much. Also on the line, of course, is Melinda, and our education today, we're going to continue working on risk models. Risk model variables. We'll look at illicit drug use, alcohol use, liver disease, and mediastinal radiation. But before we do that, just want to give a few updates. The August training manual was posted, I think the end of last week, or I saw it come through this Monday. Harvest 2 report has been released for a little while, a couple weeks now. Harvest 3 is closing on August 18th. That's going to contain dates, OR dates through June 30th of 2023. Please make sure you get your data in and cleaned up as soon as you can with those 30-day follow-ups, which would be through July 30th. And then AQL registration is open. Please go ahead and register. I have some more information on the slides, but we'll get to in just a second. Talking about registration, the sooner you register, the better. Then you're all set, and we can start planning. We're in the middle of planning a great presentation for you all for those days. And then updated risk calculator. So as many of you know, we sent out an email last week from Dr. McIlvery regarding updated coefficients and a new look to the STS risk calculator. The risk calculator variables have remained the same. We updated the coefficients that are applied to those risk factors, risk variables, to the model variables. So, and we're going to continue updating them so you have the most up-to-date risk-adjusted data for your patients going into the operating room. So the risk calculator is available online. Oh, and please be sure to put your questions into the Q&A so we can track those a little bit better. Melinda, are you hearing me okay? Somebody said they can't hear me.
I can hear you just fine.
Okay, thank you. So the updated risk calculator is available through the website and then also the email that was sent out last week. When Melinda is done with her education, we'll do a live demonstration of that, and also happy to try to answer your questions, and hopefully we should be able to do that. And then just another screenshot, another shot of the important dates for the adult cardiac. Today is our monthly webinar. August 16th, we have a quality improvement series. We're focusing on reducing vent times nationally. So that will be August 16th at 2 p.m. Central Time. August 18th is Harvest 3 close. That's OR dates through June 30th of 2023. That is a star rating period. Please be sure to get your data in and cleaned up as early as possible following those 30-day follow-ups from July 30th. Make sure you get those cases in. The opt-out for Harvest 3 is August 22nd. If you did not want to be included in analysis, you'll need to fill out that opt-out form by August 22nd. September 4th is the last day sites can consent for public reporting for adult cardiac. If you've already consented, you do not need to reconsent. If you've never consented before, but your site would like to consent, you will need to do that. And if you have any questions on that, you could please reach out to me and I will put my email in the chat box, but most of you have it and it'll also be on one of the last slides for you. Our September monthly webinar is September 6th at 2 p.m. A National Quality Improvement Series webinar will be on September 20th. And then AQO is here September 26th through the 29th. And Adult Cardiac will be held on Thursday, September 28th. Don't forget, harvest close August 18th. Please be sure to get your data in. And then I just want to highlight the General Thoracic database. If your site is performing any type of lobectomy, esophagectomies, and you're not part of the General Thoracic database, we would really love to have you be part of this. We have, I believe it was last year, we worked with US News and World Report to provide sites who are publicly reporting for the lobectomy a 3% transparency credit. You will receive biannual benchmarked outcomes with regional and national average to focus on your quality improvement at your sites. Very low fees to participate in the General Thoracic database. It's $550 per surgeon member per year, $950 for non-member per year, and a $3,000 one-time onboarding fee for Canadian and international sites. If you choose to participate, you always have the option to use direct data entry, which is free to submit your data to us. So if you just have a couple surgeons, you could be doing this database for a very low fee, getting very high quality benchmarked and regional outcomes back, be able to focus on quality improvement. And it would be great just to all be working together. We host the same type of webinars, educational webinars for General Thoracic database, and it's a great community as well. We do collect primary lung and esophageal cancer. So primary lung, primary esophageal cancer cases are required. We also collect other thoracic cases like hiatal hernia procedures. So if you have any questions about that, again, please feel free to reach out to me. I'll put my email in the chat in just a few seconds. Melinda, do you want to talk anything about how we have our AQL meeting coming up September 26th through the 29th? Adult Cardiac is September 28th. We have been working on the agenda together. Would you like to speak to that at all and provide any highlights into what that looks like? So for those of you who maybe are on the fence about registering or not, maybe we could help push you over to the side that says register for AQL.
Yeah, so we're still in the planning phases, but I think we're pretty much done with that. I mean, just finalizing it. We're going to have Dr. Huey, I think, is going to be doing a really nice maze presentation with a demonstration and then some scenarios with that. Mitral valve, we're going to be focusing on the Carpentier classification this year. Of course, we're going to be doing an aorta presentation. I'm going to be doing some Proc ID scenarios. We've got perfusion scenarios coming along. We're going to have quite a few on demand, some IQVIA reporting stuff on demand, some aorta presentations. We're going to have a perfusion scenario on demand, star ratings and Proc ID on demand. So we've got a lot of on demand things going on. And then in the live sessions, we're going to be trying to incorporate those on-demand sessions with scenarios in the live arena. So I think it's going to be a wonderful agenda for the day. It looks pretty good. And of course, we'll be talking about the aortic models. Did I miss anything, Carol?
No, I think you covered it well. I think you covered it well. Okay, we're going, thank you, Melinda. So again, Adult Cardiac will be on Thursday, September 28th. We do have options if, this is for if you're an associate member or surgeon member through the STS. This is not for sites who participate. They are, for this pricing, we're not considering it as being a member. A member is somebody who joins as an individual, as an associate member or surgeon member, and your rate is a little bit lower than those whom are non-members. So we have a one-day pass and we have a multi-day pass. A one-day pass for members $200, for non-members $250. Multi-day, which means you can come for all 4 days, is $300 for the member rate, $400 for the non-member rate, and then $500 for multi-day industry vendor rate. We are offering CEs. I don't have the count on those yet, but it'll be similar to the previous years. Usually for adult cardiac, we're somewhere between 50 and 20 CEUs. So it's not too bad of a price for the education you get, the community involvement that you get, the networking with the other data managers and surgeons. And in addition, you also get the CEUs. So
Oh, and I also
please.
forgot, probably the most important scenarios that we're going to be doing are stroke and deep sternal wound infection this year.
Oh, yes.
So I think those are going to be really good. So I forgot to mention those. So.
That's okay. Thanks for the reminder on that. Okay, well, I'm going to hand it, before we hand it over to you, Melinda, I am going to, let me just get this out of the way. I am going to just take a few questions before we get to the monthly education, just so we can clear these up. And then focus on the education you're going to be providing, the Q&A for that. Tabitha, you're asking, what surgery date does the risk calculator start with? So a little history on the coefficients in the risk calculator. When the new models were developed in 2018, they were developed using data that was from 2014 through 2014 through 2016, I believe. And then they tested it with 2.81 data. The models then were released starting with version 2.9 in July 1st of 2017. Every harvest we have, the models are updated. And by that, I mean that we look at STS as being the average, right? Whatever the STS score is the average. And then we adjust the other the variables that go into each of the model outcomes. So we have, the various endpoints of stroke, renal failure, prolonged ventilation, deep sternal wound infection, return to OR, morbidity. We adjust those, we adjust the variables that go into calculating those endpoints each harvest. So we do a little like recalibration, if you will. And when we did that, we would use what's called the recalibration factor, which is a multiplier that kind of, it's like a broader way to even out the way that the calculation was working. So we wanted to start off with, we wanted to balance it each harvest, and we would use the factors that we calculated from the previous harvest to do that for the current harvest. It was a very broad and kind of, I don't mean this in a bad way, but it was kind of a crude way of doing this. So because we have brought STS analytics in-house to our research center, we're now able to actually update the actual coefficients that are applied to each variable. So for example, diabetes, which goes into quite a few of the endpoints for the risk models, diabetes has a certain factor applied to it. So if a patient has diabetes, and depending on the treatment, a certain number is applied to that patient in conjunction with all of the other factors that go into the risk models, or however many variables we go, each variable has its own coefficient or number associated with it. We are able to adjust, because we have analytics in-house at STS, we're able to adjust each of those numbers and provide new numbers each quarter now, instead of just an overarching multiplier applied to the entire model. And I don't know if this is making sense or not. If not, I'm very sorry, and I can explain it more in an upcoming webinar with slides and things like that. But now that we're able to do that in-house, we can update those coefficients each harvest, and that's what we're doing. We are doing that. We have been doing that for the analytics, and now we're also able to do that for the risk calculator. So the surgeons are able, when they're using the bedside calculator, they're able to provide their patients with a more accurate picture of what their risk is going to be going into the operating room. Whereas before it was based on older coefficients, and we may have applied a multiplier factor to that. So it was kind of a better assumption, an assumption, compared to now where we have better understanding and assessment of those numbers. So The risk calculator is more up to date. It provides better calibration for the surgeons, and it will be updated quarterly with new coefficients in the background. You will not see any changes in that. All you'll see is that if you calculate something on one day and we update the coefficients, you may see just a little adjustment in the outcome numbers that you typically get with the risk calculator, but it won't be a huge shift. That's the only thing that you may notice. Otherwise, the risk calculator will be updated quarterly to provide the surgeons with the best risk assessment possible for the patients. Now, the vendor software, it was certified using, when we built version 4.20 in July of 2020, they were certified using the previous coefficients. We certified them for that. We have a call with them tomorrow to discuss how we can help them update their coefficients so they match the risk calculator going forward. Their risk models are still viable and they're still good. They're just not as precise as using the updated coefficients that we have in the new risk calculator. So there's that. Did I totally confuse everybody? So that answers your question, Ala, regarding the coefficients updated in your vendor's calculator. We are going to work with ARMIS and other vendors, CEDARON, all of our vendors. We have a call with them tomorrow to discuss this and how best to help them so they can update this within their vendor software. We will also be working with IQVIA to update the coefficients and come to a decision about how best we can utilize the risk score match report available in the IQVIA platform. Okay, you're welcome. So will the risk calculator embedded in the database be updated to reflect the same risk as the new just released calculator? And that's what we'll have a call with the vendors about tomorrow. Is there a possibility of in-person AQO for 2024? Yeah, the plan is that we will go virtual for 2023. We will be in person for 2024, and then we'll alternate. So back to virtual 2025, in person 2026. This way, sites who have cut funding for data managers to attend meetings will still have the opportunity to attend the virtual meetings every other year. And for those who really still have the ability to join us live and who like the networking and the camaraderie and ability to meet each other in person, we will have that starting again in 2024 every other year. We are looking right now at Nashville or New Orleans for 2024 and hope to have an answer on that coming soon. Does the new risk calculator include anything for aortic cases? No, those risk models, the aortic risk models are still being finalized and developed with the Quality Metrics Task Force at STS, and we hope to have those available in late 2023. More information will be provided as we get closer to the release of those risk models. And they're not, your other part of the question was, when will they be available for star ratings? We are not planning to release the aortic risk model for star ratings, probably not for a few years yet. So we have to let the model run for a little bit, make sure it's performing as we're expecting it, get feedback from surgeons and sites on how it's, how they're perceiving it, and then make adjustments if needed. And then we'll consider rolling that out into a star report. Online AQL will be available for $250. Yes, it's for one course is $250, which would be the adult cardiac if you wanted to do that. Do you know how long of a day is planned for AQO? Melinda, do you have any? I think
7.5 hours.
Yeah,
7.5 hours.
It's quite a long day, and we have a lot of education in addition to all the on-demand education that Melinda mentioned. And I believe we usually open that platform a week ahead of time, so you haven't you have a few days before, almost a week and a half, I think, before the adult session starts to review the on-demand content.
Yeah, and it's starting, I think the proposed day starts at 10 a.m. Central Time and goes to 5:30 Central Time, if that helps, Michelle.
So can you confirm the date range for the next public reporting? I believe we're using the harvest through reports, but Keela, if you could please email me and I can get that information for you, or we can present it. I don't have Sydney Clinton, who's over our public reporting, on the webinar with me, and I don't want to misspeak. So my email is in the chat box there. So Tabitha is saying, overall, you are saying you don't use the recalibration number anymore because each risk coefficient is able to be updated. Yes, that's right. We are updating each risk coefficient every quarter now instead of using the recalibration factor. Thank you for explaining the updated risk calculator. Is it possible to have something in a typed up explanation so we can take this to the surgeons? Let me talk. I don't know what was sent out via in that email. I thought we explained it in there. Let me double check and see what we have. And if not, we can definitely work with our marketing to get something sent out both to data managers and to the surgeons from STS. So thank you, Sarah, for letting me know that you needed something a little bit more clear. Jackie, do you think they will ever start to look at a glucose control of the diabetic via A1C to look at outcomes? Because it seems that would be better than, what did I do? That it would be better. Do you think that they will ever start to look at glucose control of the diabetic via A1C to look at outcomes? Because it seems that would be better than merely a diagnosis. Yeah, I agree with you, Jackie, on the using the A1C, and I'm not sure exactly what that discussion was when they built the model. When they build risk models, they look at every variable that we collect, and they look at that in relationship to the outcomes they're trying to better understand. So I can definitely try to look into that more for you to see what that discussion was amongst our metrics team here and see where we're at with that, if that's something we can do in the future, a future update or something. Where can we find the coefficients? They will be posted quarterly. And let me, Heidi, if you can send me an email, let me ask our research center team where they plan to post those. So send me an email. It's ccrone@sts.org. Are there any books you would especially recommend to improve our knowledge of cardiac disease and surgery? Yes, the STS ebooks, and I'll give you more information on that. Nash, harvest deadline is August 18th. Yes, you're welcome, Michelle. Okay, I'm going to hand this over to you, Melinda, so we can get going with this education.
Or we might never get to it.
We might never get to it, and that's not what we want.
So we should probably do a little bit of education. Okay,
Yeah.
everybody. So we're continuing our risk factor education this month and we're all the way down to illicit drug use, alcohol use, liver disease, and mediastinal radiation. So we're going to just go through some scenarios and see how you guys answer. Next slide. So just so you know, the illicit drug use, alcohol use, liver disease, mediastinal radiation are in the risk model. And in 2022, they were all audit fields also. So you're probably getting a correlation here. Most of your audit fields are in the risk model as we've been going through these webinars monthly. Next slide.
And that means that we pull our education from the audit. We audit the risk factors, and then we get the audit results back, and then we focus our education on the risk factors that we saw sites having a hard time with during the audit.
Yes. Okay, so question number 1. The patient uses CBD and marijuana daily. Do I code this as illicit drug use? A is yes, B is no. Do you have the poll? There we go.
Yep, there you go. Let me make you a co-host here. Hold on. A little bit of a split, Melinda.
Good split.
Let me know when you're ready to end it.
I think we can end it because we have a lot of questions. So we have about an 85-15 split, and the answer is no. And so why is the answer no? So marijuana is legal in many states. So in the training manual, it's not considered an illicit drug. CBD is not an illicit drug. It's legal in all states. So that's why the answer is no. Question number 2. If a patient is prescribed methadone, do I code this as illicit drug use? Yes is A, B is no.
Oh,
Oh, well,
they
they
did
got that
good.
one. They did really good on this one.
I think we're good with this. Okay.
I think we're good with this one. Okay, and the answer is no. Methadone is a prescribed treatment for drug abuse. It's not an illicit drug. So, next slide. Question 3. I have a patient on an herbal substance, kratom. This is an herbal substance that can produce opioid and stimulant-like effects. Do I code yes for illicit drug use within 1 year? A is yes, B is no. Oh, they're good with this one too. I get these questions. I don't make these questions up. These questions get sent to me in the mailbox. So
That's funny. A little bit of a split, but it'll be good to hear about this one. Let me end the poll.
All right. So, and the answer is no. So it's not an illicit drug. This is actually from a tree, from a coffee family native to Southeast Asia. And they use it as a supplement. It does stimulate people, but most often it's used to relieve pain, depression, and opioid addiction. So it's not technically an illicit drug. It's an herbal supplement. Next slide. Okay. I have a patient who has a history of drug use. The patient states that he takes street Klonopin for panic attacks. Can I code yes to illicit drug use? A is yes, B is no.
Yeah, I thought we were going to have a wider split on this.
I did too. Oh, that's a really close split. Okay.
It's a close split, yeah. All right, let's see. We
Let's
good?
see how we do. Yeah. And the
Okay.
answer is yes. Okay, so the patient told you he's using street Klonopin, which means he's buying it off the street. He's not prescribed that medication. So in this instance, he is using it as an illicit drug. So we would code yes to that. Okay. Next slide.
It says if a patient has a documented.
Oh, there it is. Sorry.
Okay.
If a patient has a documented history of alcohol, we're moving into alcohol. If a patient has a documented history.
Oh, we're done with drugs or going to alcohol?
Going to alcohol now.
All right.
Patient has a documented history of alcohol abuse, but his last drink was greater than 30 days before surgery. Should we code alcohol use as none? A is yes, B is no. Oh, that's kind of interesting. All right. Got a 70-30 split going on. We're pretty good there.
Yeah, I wonder if you guys think we're moving too fast. I know we're trying to get through these polling questions, but if you think we're moving too fast, just
let us know.
Yeah, send us a thumbs up emoji or something like that, and we slow down a little bit.
Okay.
I want to make sure the education's sticking, and they have time to type in questions if they have any. I'm gonna end the poll now.
So the answer is, we're crying and we're hurting them, I guess. They're crying. Okay, so the answer is yes. So this patient has a history of alcohol abuse, but he has not had a drink for greater than 30 days before surgery. So if you look at the data definition, we are to code current alcohol use within 30 days of surgery. So this patient hasn't had any alcohol in 30 days, so we would code that as none.
Wait. Oh, okay.
What?
I see. I got a little confused because it says, should we code alcohol use as none? But then, between the yes and the no, that was a little confusing to me. But I got it now. I'm good. I'm like, whoa, wait. Okay, I'm good. All right, next slide.
Next slide. I'm going to slow down. We're on alcohol.
Thanks. Because I'm like,
alcohol use is reported
click.
as 6 to 8 drinks a week. 6 to 8 drinks a week. How do I code the amount of alcohol? Do I say it's 2 to 7 drinks, greater than 8 drinks, or greater than equal to 8 drinks, or unknown? Ooh,
I think I would have chose that one too.
yeah, they're doing great.
Okay.
Very, very good.
All right, I'm going to end the poll.
And the answer is equal to or greater than 8 drinks a week. So, and we have a statement in the training manual that says when alcohol intake is documented as a range, then you're going to code the highest amount in the range. And generally speaking, you know that patients normally don't tell you how much they really drink anyway. So that's sort of why we went on the higher end of than the lower end of the range. So, all right. Next question, more alcohol. We'll probably need some after this, right? Patient assessed for alcohol use. And the response is yes. So he says he used alcohol. The amount of alcohol use is not documented. How do I code alcohol use? Is it less than 1 drink, 2 to 7 drinks, greater than 8, none, or unknown? So he says he uses it, but he doesn't tell you how much he uses.
Mm-hmm. No, I'm just kidding. Like the Brad Paisley song, Alcohol.
Well, I did really good on this one.
Yeah, for sure.
Yeah.
All right, I'm going to go ahead and end the poll. We got
You guys are too
responses.
smart for me. They're too smart for me. Maybe we'll
Yeah,
have some harder
I
questions.
think they have your number this week, Melinda.
They do. Okay, so the answer is unknown because even though you know he drinks alcohol, you really don't have any idea of how much alcohol the patient drinks. What I would do is try to clarify with a provider in this case too, because it is in the risk model. So it'd be important to be able to quantify the amount of alcohol that this patient does actually drink, since it's in the risk model.
I have a question, Melinda, on these. So say preoperative, for whatever reason, the patient comes in either post MI, MI, or for whatever reason they're unconscious, or you can't get a clear history from the patient or family member. And then you get that history after, and it's documented somewhere in the chart after surgery. Are we able to go back and code the risk variables?
Yes, I mean, if it's clearly documented that, this is what the patient was doing pre-op. I mean,
Okay.
it's a pre-op history. I mean, sometimes patients come in and you don't have any history, but then the family member shows up and they're able to give you some history. And sometimes that may be documented after surgery, but you still know that it's the history of the patient prior to surgery. Does that make
All right.
sense?
Yeah, thank you. Thanks. Okay, next one.
Next one. Think more alcohol. I thought we were done with alcohol.
Melinda, what were you doing last night when you were doing these slides?
All right.
Just kidding.
The surgeon consult notes documents 2 to 3 drinks a day, and the hospitalist note documents 1 drink a day. How do you code alcohol use? Do you say it's 2 to 7 drinks a week, greater than 8 drinks a week, or unknown? So one
All right.
person's saying 2 to 3 drinks a day, and the another person's saying 1 drink a day. So how much alcohol does this guy actually drink?
And there's 7 days in a week.
And there's 7 days in a week.
Okay. All right, there you go.
Now, I gave him a hint earlier.
Yeah, it's the
Oh.
days converted to weeks, so sometimes it gets us on polling questions.
I know.
But this is how it comes in, right? I mean, when we're abstracting
Yeah,
cases, we have to convert these to what the weekly consumption is.
Exactly.
So it gets a little tricky.
All right. So option B, greater than 8 drinks, got the highest score. So that is the answer. So again, when there's conflicting documentation of the amount of alcohol consumption, we would want to code the highest amount. So if the surgeon's saying he's drinking 3 drinks a day, that's 15 drinks a week. No, that's not 15. That's 7 times
See?
3. That's 21 drinks a week.
Unless you only drink 3 drinks
No.
a day during the work week.
Yeah.
That would be
Versus
15.
1 drink a week is 7 drinks. 1 drink a day is 7 drinks a week. So we're going to always code the highest amount of alcohol. So it would be greater than 8 drinks.
Okay.
See, it even confuses me. I have to think about this stuff too.
And who wants to count how much they drink anyway? Just kidding. All right. Next question.
Okay, we finally moved to liver disease, but this is what happens if you do drink too much, which is why it's after alcohol. Okay, that's just a joke. Sorry.
Yeah, no, that was a good connection. Good segue there.
All right. So my patient has a history of hepatitis with mono. Is this coded as liver disease? Yes or no? So we had hepatitis
Ooh,
when he had mono.
I knew it was going to be a split.
Yeah, this is a
I knew
tricky
it.
one.
Yeah, because you and I went back and forth on this a little bit too, I think, when we talked about it.
Mm-hmm. And I just put this update in the training manual. So only the really keen-eyed people, and they know who they are because they've already asked me questions about the new updates, will know the answer to this one. So it's a split. Got about a 50-50 split going on here.
Okay, I'll go ahead and end it.
All right. So, and the answer is no. Okay. So, and the reason the answer is no is because when you read about hepatitis with mono, it's usually a very short time frame. There's not any ill effects to it. It's mainly just a little liver congestion. And so we're not going to be coding this as liver disease as the other following, like hepatitis A isn't coded, E is not coded, Gilbert's fatty liver cancer is not coded, or transient elevation of liver enzymes isn't coded. And this I just put this out. So,
yeah.
All right.
And so with hepatitis with mononucleosis, that's more of an acute hepatitis.
Mm-hmm.
Where the other types that we do capture here are more chronic, right? So,
Right.
Okay, that's kind of the thought. All right, thank you.
Okay. Pre-op, the patient was diagnosed with a liver abscess in the right lobe. Can I code yes to liver disease? Yes or no? A or B? Oh, they're good on this one. Their fingers were really,
Yeah, they were fast.
they're fast on this one.
I mean, we got 200 responses in like 30 seconds.
I
don't think you're going to trick them with this one, Melinda.
No, I knew I probably wasn't, but I thought I would just throw it out there.
Yeah.
Okay. Most of the people said the answer is no, and the answer is no, because this is a liver infection. It's not primary liver disease. Okay, so we're not asking for infections of the liver. We're asking for primary liver disease, which would be hepatitis B, hepatitis C, drug-induced hepatitis, autoimmune hepatitis, cirrhosis, portal hypertension, esophageal varices with a liver transplant, or some sort of congestive okay, I can't say that word.
Enlarged liver.
Enlarged liver.
No.
There we go.
I don't know.
And the one key here is we do exclude NASH in the absence of cirrhosis. So if somebody has NASH and they don't have cirrhosis, that's not liver disease. So just keep that in mind too.
All right, next
But
question.
most people I know that have NASH do also have pretty bad cirrhosis too.
Usually it's related to alcohol abuse. NASH, that's not alcohol.
No, it's that autoimmune liver
yeah,
disorder, which is very sad. I've known some people with that. It's extremely sad. Yeah. Okay, next question. Patient has a history of autoimmune hepatitis. Is this considered liver disease? Yes or no?
I think they were listening.
Yeah, because there's more than one type of autoimmune liver disease. NASH isn't the only one. So
Okay. Are you good with these results?
I think so, 70-30. So the answer is yes. It's very clear in the indications of what we code as liver disease. Autoimmune hepatitis is one of those to be coded as liver disease. Okay. Number 12. When capturing a history of liver disease, does alcoholic hepatitis meet their criteria? Yes or no? So if you have alcoholic hepatitis, do you have liver disease? It's a good.
Yeah,
Good.
they're taking a little bit longer on this one, though. They must be looking it up. We should see who, we should look at these polling questions and see who are the first people to answer.
Oh, are we going to give prizes?
Yeah, maybe. I don't know what, but maybe something, something virtual, like a sticker or something.
We'll ask
Okay.
him. We'll ask him to speak at AQO next year.
Nobody will be answering the polling question. All right, I'm gonna end the poll.
And the answer is, they've got me laughing now. Yes. Okay. So yes, code history of hepatitis, since the patient has a history of alcoholic hepatitis, which technically is drug-induced hepatitis. Alcohol is a drug. And so if you have alcoholic hepatitis, then you can code yes to drug-induced hepatitis, liver disease. All right. The patient has a history of liver cancer. Can I code this as liver disease? Yes or no? This is good.
Yeah, it's good.
70-30.
Okay, let's end it.
All right, we're going to end it. And the answer is no. So remember, we have instructions. The following are coded as liver disease, and liver cancer is one of those. And the reason is we have a place to capture cancer. So we have a specific field. If the patient has active cancer within 5 years, we capture that in the cancer field. So that's where this would be captured at.
Makes sense.
Okay, question number 14. Would ischemic hepatitis be coded as liver disease? The patient presented with septic shock and there's no documented prior liver history. Yes or no? So this is like shock liver.
Are you good
That's
with
good.
that, Melinda?
Yeah, I'm good. So
Okay.
most of the people chose the correct answer, which is no. Ischemic hepatitis or shock liver is a result of most likely the sepsis that's going on. It's not primary liver disease. See, this patient, the key was that this patient didn't have any documented prior liver history, so it's not really primary liver disease. It's a condition that was caused by the sepsis, so we wouldn't capture that as liver disease.
Thank you.
Okay, I think this is the last liver question.
I know it's been a busy day with liver alcohol. I feel bad for people's livers after all this talk.
Can I calculate the Child-Pugh classification based on documentation in the medical record? Yes or no? So what it's saying
Ooh,
is,
that's a
can the
good
data manager
question.
calculate the Child-Pugh classification? Yes or no?
That's a good question. We saw that one, right?
Mm-hmm. I can't see the poll. What did I do with it? I don't know. Oh, there it is. I see it now. Okay.
Got it?
Mm-hmm.
All right. We'll end
All
it
right.
here. Okay.
I think we'll end it. So 90% of the people say no, and that is That is correct. It is the responsibility of the provider to calculate the Child-Pugh classification and document the score in the medical record. So if it's not documented, just code unknown, because we don't expect data managers to calculate that classification themselves.
Yeah, I would just add if it's not documented and it is, and the patient does have a history, this is for cirrhosis, right, Melinda? We capture Child-Pugh. If the patient has a history of liver cirrhosis and there is no Child-Pugh classified, you may want to work with your surgeons or surgical team to ask them to please start documenting the Child-Pugh score for you.
Yeah, because it's in the risk model.
Yeah.
Liver disease is and all that stuff. So it would be helpful.
I don't,
to get
yeah,
all
I don't
that
know
done.
that Child-Pugh is. We just started collecting that, I think, in
Maybe not.
2.9, but
Probably
it's
not.
still be very helpful because we don't know if we'll be able to add those in the future. So the more data we have for something, you know, cirrhosis, the severe, where we can get a classification, that would be helpful. So. Okay, that's my speech. Oh, Melinda, you got
One
more
more.
questions.
One more. One
Wait,
more.
there's
Okay,
more.
I think this is the last
Wait,
one.
there's more.
It's the
Okay.
last one, I think. Well, we
All
still
right.
have mediastinal radiation.
Oh,
Patient
my
with
Lord.
positive, I know. Patient
just
with
kidding.
positive hepatitis C antibodies in their blood tests. Can I code this as liver disease? So they've got positive hepatitis C antibodies in their blood test. Can I code this as liver disease? Yes or no?
This is a tricky one.
I know. I got this question a lot, and I finally took this to the core group last month and got an answer from the surgeons. And I just put this update in the training manual.
Don't tell them now, they'll know where to find the answers. No, I'm just kidding. All right.
And
I
it's about a fit. We got a little 50-50 going on
Yeah,
here.
about
And so
50-50 split.
the answer is yes. So basically, if you have a positive antibody test, it means at some point you've been infected with Hep C. So that means you've had it. Doesn't mean you are still active, but you have had it in the past. And when you look at the time frame for liver disease, it's I think it's birth to OR entry. So yes, the answer would be yes. If you've got positive Hep C antibodies, you can code yes to liver disease.
Perfect. Thanks, Melinda. Next one.
Okay, now we're doing mediastinal radiation. I think there's only like 4 questions. Patient had laryngeal cancer and received radiation and chemo. Would I code yes to mediastinal radiation? Yes or no? Laryngeal cancer.
These are some good ones that you're going over, because even though the splits aren't, I mean, this one's a little bit closer. We're pretty close on option A and option B, but even, you know, if there's some people out there who are having a difficult time, this just kind of reminds us that we need to review the training manual each month and look at the FAQs that you put out, the FAQ sheet you put out. So this is very helpful. Thanks, Melinda.
You're welcome.
I'm gonna end
yes,
this.
like
Okay.
70. So, and the answer is no. And you know what? I give you a little picture here. If you look to see where they actually do the radiation for the laryngeal cancer, you can see it's not anywhere. I mean, it's not in the mediastinum. It's right up there in the neck area. So this would be no. But it is kind of a tricky one. I get this question a lot. So it's good to bring it up. Okay. The patient has a history of lung wedge resection with breaking mesh radiation. That's like radioactive seeds in 2015. Is this coded as mediastinal radiation? So they've had a lung resection. They had some seeds put into that resected area. So is this considered mediastinal radiation?
Good you reviewed this one. I remember this, this came back from, I think we had a similar question in the previous version too, about radioactive seeds.
This goes back a ways.
Yeah, this is
but it's a good question.
Yeah, I'm gonna go ahead and end the poll now.
It's about a 60-40 split.
Yeah.
And the answer is no. So this was actually a core question from quite some time ago, but basically it's low dose rate iodine, 125 seeds. So the impact is fairly low. So it's not considered to be full chest mediastinal radiation. And this is in the training manual. Yeah, so the answer is no, and it has to do with it's not beam radiation, it's seeds, and they have a very limited range.
Yeah, that's a good distinction. Thank you. That's great. Okay, next.
Okay. Patient previously had coronary stents and brachytherapy radiation via catheter for in-stent restenosis. Should this be captured as mediastinal radiation? So he's had a stent, and they went in and did some brachytherapy radiation for an in-stent restenosis. So yes or no, is this mediastinal radiation?
I didn't even know they could do this.
Yeah, they do this all the time.
Oh my gosh, I'm learning so much.
Yeah, it's pretty amazing.
You're gonna have to teach me more about this one.
Well, they're basically going in and just like they're doing a PCI, except they're radiating instead.
Really?
Yeah. It's kind of interesting.
Is it done for a certain type of stenosis?
I think for people that they can't put a stent in, they're having difficulty, and they try this. That's my take on it without researching it too much. Okay, and that's a 20-80 split, and the answer is no. Okay, so this is not really mediastinal radiation. Mediastinal radiation can cause scar tissue and can lead to increased bleeding and make harvesting difficult of the mammary and interfere with healing. This is just coronary artery radiation, basically. So it's not going to have to do, it really doesn't have anything to do with the chest wall. So that's why the answer is no. It's inside the artery versus being outside on the chest. Okay, I think this is the last question, but there may be one more. If a patient had protein beam therapy for breast cancer in 2016, would that be yes for mediastinal radiation? So proton beam therapy. Yes or no for breast cancer? (80-20).
Are we good?
Good.
Okay.
And the answer is no. Now, I didn't put this in to be a trick question, but proton therapy is a very unique type of radiation that can precisely target and deliver high doses to kill a tumor. But it's very specific and it's very highly targeted to just where it wants to go, right? So the goal and the reason people use the proton therapy is that it minimizes damage to nearby tissue and critical organs such as the heart and the lungs. So that's why this specific type of radiation therapy for breast cancer is not mediastinal radiation. Normally, if you have the old-fashioned type of radiation for breast cancer, yes, that does cause some damage to your mediastinal area. So yes, that would be mediastinal radiation. But this specific type here, proton beam therapy, no, it's a new type and it's very precise and it does not affect the nearby tissue and organs. So that's good. Just new learning.
Yeah, that's great. And it just shows how science advances, right? I have a question for this one, though. It's interesting. What if they just say radiation, patient had breast cancer with radiation therapy?
Well, then you don't know. You don't know. You wouldn't know. I would probably code mediastinal radiation because that's generally historically speaking, that's how it was coded. But if you know the type, then you are able to differentiate between the old fashioned way to do it and this is the new way to do it. And I don't know how many people get this versus how many people get the old fashioned just mediastinal beam going on. So
Okay. If it doesn't specify protein therapy for the type of radiation therapy, then we should default to the regular or historic way that radiation has been used for these types of breast cancers.
I
But
would think so.
okay,
Yeah.
best bet is that if it needs to say proton therapy in order to code this as a no.
Yes.
Okay.
See, now here was another one. My patient received mediastinal radiation 25 years ago for breast cancer. Do I code yes to mediastinal radiation? And you guys should all get this answer right, because we just had this discussion.
We're going to spend 10 more minutes if you had it. We're going to go back over 20 and 21 if you don't get it all right.
So I know everybody, thought everybody was going to get this right. So this is 25 years ago, mediastinal radiation for breast cancer. And the answer is yes, this is mediastinal radiation, especially since it was done 25 years ago. That's where they just full on radiated your whole chest when they were doing your breast cancer treatment.
And those 10 people that coded option B as no, Melinda and I will be reaching out to you to set up 2-hour-long conference calls to go back over slide 20 and 21. Just kidding. But I'm just kidding. But if you all have any questions on this, please put them in the question and answer box so we can review it again, because it is a little tricky when we're talking about radiation and then we're talking about specific types of radiation, and they're not always coded the same way. So if you do, I certainly understand how this is how this can be have tricked up a couple people. So if you have any questions, please put them in the Q&A and we'll get to them.
Yeah, and as technology advances, my suspicion is we're going to see less mediastinal radiation because people realize that it damages things, and so they're going to probably try to have new therapies that are less damaging.
Yes.
Thank you,
Melinda.
everybody.
Yeah, thank you so much. That was really great education as always. And we're going to go over to some questions now. I know we're over time, Melinda. Do you have extra time to go through these questions together?
Yes. Yes.
Okay. And if anybody needs to leave, please go ahead and do so. These will be recorded, but hope you can stay on just at least to get through some of these. So the first one is from Joy. Joy saying she's still unable to receive emails from the STS, and she's tried with the STS team and the IT team on her side to figure it out. Could somebody please connect with her? Joy, I did put my email in the chat box, and it's also down here, ccrone@sts.org. Please email me and I'll put you in contact with somebody. Oftentimes the sts.org needs to get whitelisted at your site, or for some reason it got blocked on somewhere in between the communications. We can certainly help and work with you on that. Are there any books you would especially recommend to improve our knowledge of cardiac disease and surgery? So the STS does have what's called the ebooks, and let me see if I can pull those up here. Hold on one second. So I'm going to go to the STS page here and see if I can find it. We kind of changed. Here it is. Under education, there's this link here to the ebook. There is a fee for it. You can subscribe to it, but this is great. It has really great pictures in it. Very good education. I think we have, I know Leanne, my coworker Leanne uses this quite often. What does it say? Most current, continuously updated resource, which is great because it will never be outdated in the specialty, authored and edited by the more than 600 leading surgeons from around the world, with over 350 interactive chapters in all main cardiac thoracic surgery domains. So I think this is the book that I would highly recommend the STS cardiothoracic surgery ebook. Is there an app for the new risk calculator? I think the risk calculator is it's mobile friendly, but there's not an app built for it at this time. It is something that we are considering to come out with in the future. When will the public reporting refresh using data ending December 2022? I think if you could please reach out to me. I have a feeling we shifted that time frame to use the Harvest 3 data instead of the Harvest 1 data. So please reach out to me, ccrone@sts.org, and I can put you in contact with Sydney, who knows that way better than I do. I would like something more clear also. I did not receive the email last week. Understood, Tracy. Again, let me see what I have. Otherwise, just please email me and I'll see what we can send you, and I can even forward you that email that was sent last week, so you have it. Oh, the email about submission. This question is from Molly. The email about submission. For everybody's info, the email about submission was regarding making a new submission between harvest to make sure you're included in the next harvest. Molly saying the email about submission. Does this mean we have to submit the previous 6 months every submission? Meaning if there was a month from the previous submission that did not have any updates, we are now having to resubmit it at the next submission deadline regardless? No, that's not what that email was referring to. For Harvest 1 and 3, which are star ratings, you need to have made a submission since the previous star rating to be included in analysis. So for Harvest 1, that includes that would include you submitting a case from the Harvest since the Harvest 3 analysis. Harvest 3 analysis includes dates through June 30th of that year. So for the upcoming Harvest 1, you would need to submit a case with the OR date after June 30th to be included in the submission. For Harvest 2 and 4, we are looking at the previous submission. So if you had not made a submission since you updated your data for Harvest 1, if you didn't make a submission from January through March with an OR date from January through March, you will not be included in the Harvest 2 submission. It just means that you want to make sure your data is in the warehouse, that you have new data in the warehouse for submission for the new months that are covered in those analytic periods. So what if the provider documents not currently for alcohol use? Melinda, how would you like, what do you think about that one?
Well, I think I would ask for clarification because I don't really know what that means. Does that mean not currently today, not currently last week? We don't know what that means. You probably would put unknown if you don't have any clarification. I mean, I don't know what that means. It just seems pretty vague.
Yeah, like not currently during the office appointment, or
Yeah, I mean that's what I'm saying. I don't know what that means. It's too vague.
Oh yeah, I hear you. Next question was, I did not hear about the Harvest 3 deadline. Is it still August 18th? Yes, the Harvest 3 deadline is August 18th. Melinda, is it acceptable to use nursing documentation to document how many drinks per week the patient drinks?
Yes, in fact, that's quite often where I go first.
That is exactly where I would go first, because we do all those very lovely nursing assessments upon admission that take many of our hours away. So, and that's one of them, right? Drinks, how much do you drink? Or do you drink how much? And how would you code the alcohol use when the patient states social or occasional?
That's another one of those, that you really need to clarify, because he might be social every day. We don't know. I mean, it's one that's very vague. I would want to clarify that, or I would just say unknown, because you don't really know.
Yeah. If there was a conflict in the chart, I thought you documented unknown.
Well, I think that this must be talking about the alcohol and the conflicts about the amount of alcohol. If there's specific direction in the training manual as to how to code something, then that's what you go with. And so for these questions, this alcohol question that we talked about, there is specific direction in the training manual as to how to deal with conflicting documentation. So that's what you would do first, as opposed to code unknown.
Thank you. Regarding question 8, which I've pulled up on the screen here.
It's the same one.
Oh, okay.
Conflicting information. So again, if there are specific instructions in the training manual that deal with conflicting information, because sometimes you will see that certain areas, alcohol is one for sure. I can't think of another one off the top of my head, but I think there are a few others. If there's specific language in the training manual, then go with what the training manual says, because I have provided some instruction to make life easier for you when you see conflicting documentation in this particular situation, such as alcohol, because I know you're going to see it. Probably see it every day. And so we were actually trying to make your life a little easier. as opposed to creating conflict. So you will note that sometimes there are caveats in the training manual, and this just happens to be one of them.
Okay, thank you. What if they have cirrhosis as well, along with a history of hepatitis and mono?
Well, if they have cirrhosis, they have liver disease. I mean, if they've had I'm assuming you're saying they have cirrhosis too. So yes, that would be liver disease if they have cirrhosis.
Thank you.
But the question was just a person that just has hepatitis with mono. That was the question we were talking about.
Yeah, and I knew this one was going to be asked because I think we just need to go over it one more time.
Well, she told me she understood it at the end, but
I thought
I got rid of this question, but I'll go over it one more time. So
I'm sure other people probably have it. So it says, can you explain why you said liver cancer is not considered liver disease?
Because liver cancer is cancer. We have a specific field, sequence 500, where we capture cancer. So that's where we would capture the cancer history. Liver cancer is not considered primary liver disease. It is cancer, and we have a field for that. So we would capture it in the cancer field.
Perfect. Thank you. I put up slide number 2 again. Okay, autoimmune hepatitis. Does autoimmune hepatitis count as being immunocompromised?
Not necessarily. It depends on if you are on medication for that condition, and a medication that would affect your immune system.
Yeah, I think you have some very good examples in the training manual on coding immunocompromised, the field. Okay. It is extremely difficult to get the physicians to document NYHA, let alone Child-Pugh classification. Yeah, I'm sure it is. Can you please go over the new exclusions for the harvest submission beginning September 23, harvest 3? And I think I did. Let me know if you still have questions on that. Essentially, just make sure that you have submitted new data since the last harvest to be included in the next harvest. So you have to make a submission since the last harvest to be included. If you do not have any new data to be submitted, then it's not going to be, your data will not be analyzed, because we're essentially missing 3 months worth of data, and we're assuming that nothing has changed at your site regarding the outcomes of the previous cases. So please, you make sure that you submit new cases from the next harvest so you can be included, or from the last harvest so you can be included. What if they've been cured of hepatitis C?
They still had a history of it from birth to OR entry, so you would code it. Yes, they still had that history of hep C.
Thanks, Melinda. And then Jackie, I think, is helping me out here. She says it's for people who are not good cabbage candidates and where they cannot restent. So that was related to the radiation. What is it called? Radiation
Brachytherapy, the
brachytherapy.
brachytherapy.
Thank you. And I have heard of brachytherapy before. I didn't realize that that's what it was. I need to get back in school. Will the proton beam therapy information be added to the mediastinal radiation definition?
I can add a caveat in there. I just looked, it's not there. This is, I found that in the FAQ mailbox though, with an answer that came from the core group. So it probably just didn't get put in the training manual. So I'll add that. It's good. Thank you.
Thank you. And then Lori says brachytherapy mostly used to treat recurrent in-stent restenosis, especially if multiple layers. Thank you all very much for the additional information on that. Erica, if a patient had mediastinal radiation, does it automatically mean that they have a hostile chest?
Generally speaking, yes.
Will emails be sent to sites that are not meeting the mortality status threshold prior to the star rating harvest submission deadline? Yes, Anne Marie, we try to send those emails out about 2 weeks before harvest close, and give sites time, to get their 30-day mortality status in for the cases that they had towards the end of June, which would mean that they're probably updating those cases last week and this week. And then we will send that notification out. I'm thinking today's the 2nd, the Friday is the 4th, which would be the 2-week mark prior to harvest close. I'll probably get those emails out the beginning of next week to give some time for sites to clean up their data. In addition to that, we are working on a STS executive summary that will be available to sites and to surgeons and to all those who log onto the IQVIA platform. And in that executive summary, you will be able to see where you're falling for each. Let me see if I can pull that up if you all have a second. See if I can pull that up real quick to just show you a screenshot of what this will look like, because it's going to take the place of these emails I've been sending out. And I think you're going to like it. So it's coming soon. IQVIA's building it. We have just finalizing the change order that we signed with IQVIA for this. So it should be out within the next month or two. Hold on 1 second. I just have to find where I put it. I didn't realize I was going to talk about that today. I would have had it pulled up. Hold on. Oh, here we go. Okay. This is a very rough draft of what it will look like. And I know you can't see this right now very well, but let me see if I can make it bigger. Oops. Is that my other screen? This is just a taste of what's coming. And we've been working on this for quite a few months. So can you all see that? I know it's small, but essentially what you'll see, it's a community page. So when you log in, this is where you'll land. This is just a rough draft. I'm updating the colors with IQVIA, but you'll have your, instead of having to go to multiple places to find this information, you'll have a few of your star rating available right here for all of the outcomes. And then we tried to pick some high resource utilization outcomes. So we have ICU times, post-op length of stay, post-op total vent hours, total blood products, which is intra and post-operative. This will show you your real time, where you are at real time for the last, say this is 2018, 2019, I don't know, 22, whatever. It'll show you 3 years worth. They're updated in real time. So as you're updating your data, it will show you these will change against the STS static benchmark from the last analysis. It will show you, so we focused on ICU time, post-op length of stay, post-op vent hours, and blood usage. And then down at the bottom, we have a current harvest missing unknown % for analysis. And we're going to do that kind of red, yellow, green. So if you are at risk for not being included in analysis, you will have a red bar here. If you're getting close, but not at the over 2% missingness, you will have a yellow bar. You really need to focus on those. And if you're green, you're good to go. So the goal would be to get all greens there. And we're going to report them out for the mortality analysis for each of the procedure types, and then the NQF part of the CABG analysis. You will have your eligible counts here, and you will have your missing patients. This currently, you can't see it, but it will be a drill down. So if you're missing, and we have a little bit of language that we're going to add here about what is included in the mortality analysis. If you're missing any of those cases in 2020, you can click on the 4, and then over to the right here, you'll have a case list populate. So that is coming, and I hope you like it. Hope to have it out within the next month or so for sites. So that will replace these emails that we send out manually, which do not update as you update your data. So I'm glad I get all the hearts. Thank you. I'm excited about that. And I think all of our surgeon leaders are excited to present that to you all. And also hopefully helpful for the C-suites and to share with your surgeons as a quick print and here you go kind of thing. So thank you. Social and occasional alcohol use is documented in the training manual. Thank you, Marina.
Yeah, I just saw it. I saw it. It is.
It's in there.
It is. So if they say occasional, you can say less than 1 drink a week. If they say social, you can say 2 to 7 drinks a week. So I can't remember the exact question, but you had those 2 different time frames. So I guess I would take the highest, which would be social, which would be 2 to 7. I think one was occasional and one was social, but I don't remember exactly the exact question. So 2 to 7 if it's a social drink.
Thank you. Christy says, non-related question. Is there a national benchmark for STS risk calculator discussion for isolated CABG? And I'm not sure exactly, Melinda, I don't think I'm understanding the question.
Well, I think what she wants to know is, do we have like a rating, like where her site stands versus the STS, and how when they discuss the calculator, and that would probably just be found in the harvest report. I mean, it's not a national benchmark, but certainly the data would be in there. Is it, Carol?
I think it is. I think it's probably in the let me see if I can pull it up here. And I know we're way over time. Hold on.
Yeah, I've got to go at 1:30 for sure.
Okay. Yeah, no problem. Let me see if I can log in here. Of course. Let me try to get my login here.
Christy said, yes, I'm correct in my thinking about what she's looking for here.
Okay. I think it's in the participant dashboard, which is the raw dashboard. And the STS discussed, risk calculator discussed, Melinda, is that in the operative section, I believe?
Yes.
All right, let's see if we report that out.
I believe that's where it's at. Hold on. It's sequence 1966.
I think it's one of the, I think that's one of the very first questions in the operative section, if I remember correctly. Yep, here it is. So this is the operative. I chose the operative section. The first question here is indicate whether the STS risk calculator score was discussed with the patient family prior to surgery. The STS benchmark, yes, the risk calculator was discussed. The benchmark is 51 or 52%. The site is at 37%. So I hope that helps. That's in the participant dashboard. under operative. What do I need to do if I'm not receiving emails about STS announcements and updates? Hannah, please reach out to me at ccrone@sts.org, and I can put you in contact with our marketing team, who is very good about helping sites figure out what's going on or where the emails are going. And you're welcome, Christy. But no code for not done.
I don't know what that means.
I don't know what that means either.
I'm sorry, Julia.
And then Hannah, can IQVIA make the dashboards bigger, meaning risk score? The risk score, so you have the missing, the NA not applicable. Those are for emergent salvage cases or cases with no risk model available, like aortic procedures. You have no, the STS risk calculator score was available. What does it say? No, STS risk score calculator was available for scheduled procedure, but not discussed with the patient or family prior to surgery, or the discussion was not documented. And then yes, the STS risk calculator score was done. Yeah, so I increased my font on my IQVIA screen just by increasing the font because it's very small. The other thing I want to tell you, I learned this, I did that by like, what is it, like Shift plus or yeah, Control plus on my screen. Control plus and Control minus on Windows desktop. The other thing I want to tell you I found out is that when you open the screen and it looks like this, if you right click in one of this section, this is what you want, you right click here and you get maximize visualization, it actually makes this the whole screen. So you don't have to scroll in that small tiny box. And then to get back, just move your mouse around and you get here. The other thing is you can make this go into a new window, or where did it go? I forgot which one it was. I thought it could go into a new window. That's what Melanie had showed me, but I think this is nice. You can have it all right here. So you see that pretty easily. And then to get back, you just move your mouse around and go to this double arrow pointing to restore the visualization layout. Okay. When the STS risk score is not done at all, you code it as either not applicable if it was an emergent salvage case, or if it was things for like an aortic case where we do not have a risk model, or if it is something like we have a risk model for, say, CABG or AVR or CABG AVR, you're going to code no STS risk calculator score was available, but it was not documented that it was discussed with the patient.
Right, meaning that it could have been calculated.
Yeah,
It was available, but they didn't do it.
correct. Next question is, can we filter by IQ? Can we filter IQVIA non-analyzed dashboard by surgeon? No, we do not have the ability to filter by NPI. That was an STS leadership decision. We have made available the surgeon level composite, and we are making available surgeon reporting, which that's something coming in the next few months, and we'll talk more about that in upcoming webinars. But the surgeon level composite is risk adjusted outcomes the surgeon needs to consent to. It's delivered to the surgeon's IQVIA platform, and the surgeon then can distribute them if they choose to with their partners or hospital administration or whoever they want to share that with. That's up to the surgeon. If your surgeons are interested in that, Marissa, please have them email me, and I'm happy to share information about that. Thank you both very much. I enjoy the scenarios and learning something every time. Appreciate you. Thank you, Mary. We appreciate you too. Julia says muchas gracias. And with that, I guess we are done, and we did really good. Thank you all so much. Thank you, Dr. McGilvery, if you're still on with us, for joining. We loved having you, and hopefully this was a great webinar for all. Thanks again all very much. And Melinda, as always, thank you.